All right, good morning, everyone. I'm going to give it a couple minutes to get started, give everybody a chance to call in. But I'm here today with Dr. Haider and Dr. Strosberg. I'll let them introduce themselves, but today will be an open discussion, Q&A, and our third FLaNET webinar that we're having monthly.
Hi, I'm John Strosberg. I'm medical oncologist at Moffitt, and my focus is exclusively on neuroendocrine tumors.
Hi, good afternoon. It's nice to be back with our FLaNET community, hopefully safe and dry from our storm. And I'm also a medical oncologist focused on neuroendocrine oncology at Moffitt Cancer Center.
All right, so we have a few questions that we can get started with, and anybody that's called in, you're welcome to either raise hand so that I can unmute you or put a question in the chat in between. But we'll start with the first question that was sent in, which there were a couple about alpha PRRT. First one is alpha PRRT better than the FDA approved PRRT, and who do we contact to get on the treatment? So, John, do you want to take that one?
Sure. So alpha PRRT basically uses different types of radioactive isotopes. Lutathera or lutetium dotatate, which is the FDA-approved PRRT, is a beta-emitting isotope, meaning it emits high-energy electrons. Alpha PRRT emits much larger particles. It's 2 protons, 2 neutrons. So it's basically a helium atom. So it's a much heavier particle at a much shorter range. And in theory, it can induce double-strand DNA breaks. In other words, induce more cell-killing effect than Lutathera does. So we hope that it's more effective and less toxic. But whether it is remains to be seen. We don't have any head-to-head comparisons yet. We're doing several trials, one using lead 212 dotatate, which is a type of alpha PRRT, and the other using actinium 225 dotatate. The latter trial is a randomized trial for patients who have already had Lutathera. So it's comparing actinium dotatate to a different standard of care. We do have slots on that trial for patients who have already received Lutathera. The other trial will also be for patients who have also already received Lutathera, but we don't have any slots on the lead trial right now.
Okay. Another question.
I would add a comment, Dr. Strosberg. I think you would agree that this class of medications is growing, which is exciting. And may offer more options for our patients. So in terms of the class of medications, but also the option to show retreatment for those patients who have successful outcomes from their first-time treatment.
All right. A piggyback off that one is, why can't we prescribe the alpha PRRT off-label, similar to what we do in other therapies like immunotherapy that's still under trial for most neuroendocrine tumors?
Well, that's an easy one. Off-label means that you're using an approved drug, an FDA-approved drug that can be prescribed. You're just prescribing it for an indication where it's not being used. These alpha medications are just early on in their clinical trials, and they're not approved for treatment. Now, I should say there have been places in the world where nuclear medicine drugs have been produced in hospital and prescribed prior to any regulatory approval. And that was the case with Lutathera or lutetium before it became known as Lutathera in Europe and other places for many years. There are places in the world where you can probably get alpha despite lack of approval. India is one of them. But it's not available anywhere in the United States or Europe outside of a clinical trial, as far as I know.
Dr. Haider, why are there so few options for poorly differentiated neuroendocrine cancers?
Well, I think that I want to highlight that there are a lot more research efforts to expand our current seemingly limited options or not well identified and sequenced options. This is a rare type of cancer. And we don't have big trials with big numbers to show what is best and how to approach care. For example, starting with chemotherapy, adding on immune therapy to that. Should we start with immune therapy, etc.? So at present, I think the rarity of the condition, as well as if there is a delay in understanding it and getting too sick to start treatment, can also be another limitation. But I am happy to share that clinical trials are growing. We have one that is open and active at Moffitt Cancer Center that is looking at first-line treatment, meaning the first treatment for patients with this type of cancer if they are not able to undergo surgery, which utilizes chemotherapy in combination with immune therapy. So I think that the future is going to offer more defined sequencing as well as more options and combinations.
Anything specific that both of you are excited about in that field?
I think
there's oh, sorry, go ahead, Minna.
I think the expanding role of immune therapy and understanding which patient and what kind of tumor is going to respond best. I think right now it's very open and we just try it, and that's something I'm looking forward to expanding.
Yeah, there's a trial that's going to be opening in various places in the United States using an antibody, bispecific antibody. So it targets something called DLL3 as well as T cells, and the purpose is to bring immune T cells into contact with the tumor. We're hoping to open that at Moffitt. There have been some issues recently with trying to open trials quickly at Moffitt, but we're hoping to have it available sometime by early next year for patients with poorly differentiated neuroendocrine cancers who have received at least one line of chemotherapy.
It's exciting. And that will be, once those studies are active, for any patients who are looking, the clinicaltrials.gov website is updated in real time when a study is open, and then with which sites are open. So you can keep a lookout on there. This question's for both of you, because everybody will have kind of a different practice sometimes. So how's the decision made for how far apart my scans are? And piggyback off that, why do we not get PET scans with every time point, with every scan time point, if it shows our disease more clearly?
I can take the first question, Dr. Strosberg, and then you can expand about the PET scan if you like. So I think whenever I meet with a new patient, and I reiterate this with my long-term patients, is that neuroendocrine tumor really is an umbrella term that encompasses a lot of different types of cancers, and even more deeply, we can understand each tumor more uniquely over time. So for low-grade tumors, they don't tend to grow at a fast rate, so you can control how many CTs one is undergoing per year, and the 6-month interval is very reasonable and fits that pathology well. However, we have to be open to picking up on new symptoms that might help us understand that we should get a CT scan sooner. So I always tell my patients, you have your upcoming appointment in 6 months, but these are signs that would help me understand we need to pull it forward. And so it's not an inflexible decision. But initially, especially if there is an understanding of tumor behavior over time, you can feel even more confident that that time interval is fitting.
Thanks. And, to answer the question regarding the PET scan, PET scans can be better than CAT scans or MRI for certain circumstances, but they can also sometimes be misleading. For example, more or less brightness is not always correlating with progression or improvement, whereas CAT scans or MRIs are usually better for providing precise tumor measurements. So each have their advantages. We can't, it's hard to get PET scans every time for all staging studies, and the guidelines don't recommend that. And, it's not generally covered by insurance to be getting PET scans at every point. So there are many reasons why we don't necessarily get PET scans on every surveillance interval, with the exception of patients whose PET scans are more informative than either CAT scans or MRIs.
Thank you both. What are some questions that we should be asking at the initial consult appointment? Again, both of you can kind of give your perspectives on that. What's important for you as a physician for a patient to know?
I think, the first start of the discussion includes understanding what type of tumor we're dealing with uniquely for our particular patient. And so in a day, if we're seeing 15 patients, the discussion is really different for each patient. And so taking the time and beginning to really explain where a tumor fits in within a spectrum of disease is incredibly important. And I think that hearing that something is rare can be scary, but then taking time to understand the landscape of treatments, even if I'm offering one to start, but also anticipating what the future can look like, can bring about reassurance, but further deeper understanding of what we're working towards.
Okay.
Yeah, I would agree. I mean, I think it's always good for patients to have a good understanding of, what kind of neuroendocrine tumor it is, what the stage is, although, stage 4 can mean, which means cancer is spread outside of the primary of the organ where it originated, can still be associated with a good prognosis in neuroendocrine tumors. It's still always a good idea to know where the cancer originated if we can figure it out, what the stage is, what the differentiation and grade is it producing hormone? These are basic features of neuroendocrine tumors that are always good to know. As far as prognosis, we can provide sometimes sort of a general sense of prognosis, although it's very, patients always want to, are looking for information on, or usually looking for information what prognosis is, and that can be sometimes very difficult to provide with any sort of specificity, given the fact that there's such a huge range of neuroendocrine tumors and different people can have vastly different prognoses, even with relatively similar tumor types.
I think another important point that I really value with our team here at Moffitt is that we really approach the care as a multidisciplinary team, and the nature of providing care for neuroendocrine tumors really is not one physician, but surgery, nuclear medicine. Our pathology team here is incredibly important to us, so I make that part of our discussion as well.
And with that probably comes outside doctors and managing, most people are not just coming to one cancer center. They may have a local oncologist, and managing that relationship. What do you recommend that patients do so that they can be in control and advocate for themselves in that scenario? What are some suggestions you have?
Well, I think Dr. Strosberg and I share a similar experience where we value partnerships with our colleagues in the community, and we have good relationships in that sense. And patients should not feel a stressor about that, where they have to change their oncologist for their chronic care, but we become part of the team at check-in points. Dr. Strosberg?
Yeah, agree. I mean, we work with local oncologists. We're not, we definitely don't try to steer patients to get their treatment at Moffitt unless we feel that Moffitt can offer something that's not as easily available or done, or with as much expertise as in the community. So, for example, somatostatin analog shots, sandostatin or somatostatin. If the trip to Moffitt or Tampa is long and people don't want to come to get their shots here, we can arrange for them to get it. We would like to arrange for them to get it through their local oncologist, or even in some cases injections at home. Same with following patients on medications like Afinitor, for example. Patients often see their local doctors and then come to Moffitt for their scans, or in some cases do their scans with the local doctor and then just return if there's any evidence of progression.
You talked a little bit about symptoms that patients can have. One question here is, can you talk a little bit about carcinoid heart disease and any symptoms that we have to look out for? I think to also piggyback off that is, when a patient does have a hormonal syndrome, how to tease out when the symptoms are related to, the cancer progressing, or maybe this is just a new normal for them at a certain point.
So I can take the carcinoid heart disease part. In patients with carcinoid syndrome, meaning flushing and or diarrhea and elevated urine 5-HIA or blood serotonin, those patients are at risk of developing carcinoid heart disease. It usually happens in patients whose serotonin or 5-HIA levels are fairly high above normal, usually at least 3 to 4 times above normal for a long time. But those are the patients who should be screened and have, there are several ways of screening, but generally we recommend, once yearly echocardiograms, but it's important for patients to bring up any symptoms that could be suspicious for carcinoid heart disease. So shortness of breath with exertion, leg swelling, those could be symptoms of carcinoid heart disease.
And I think, it's important to not allow symptoms to build such that it becomes a severe condition. Ideally, we want to capture changes early on because intervention is easiest at that time with a cardiologist or a cardiothoracic surgeon. And I want to highlight the subtlety that can be found in valvular disease, and an experienced cardiologist who is well versed in providing that expertise is invaluable on our team. In terms of hormonal syndrome, at diagnosis, our hope is that once we start treatment, there is improvement and potentially resolution or great control of symptoms. So certainly if symptoms are relapsing on treatment, that would prompt an earlier discussion and earlier investigation than, waiting until your scheduled appointment. And then, some tumors can be quite profoundly symptomatic, like ones that release insulin, where it becomes incredibly important to harness control of that for overall safety and well-being.
All right, thank you. Another question here. I'm progressing on scans, but feeling the best I have in a while. Do I need to start treatment right away? And how long can I wait to start? I think that's a little bit specific, but generally speaking, when you're having conversations with patients who may be progressing on scans, but feeling better than they had before, how do you make the decision to start treatment right away or delay further?
Yeah, that's a tough one. It really depends on how much progression we're seeing on scans. And that's often a problem in neuroendocrine tumors because progression can be relatively slow sometimes and pretty subtle between one scan and the next, which is why it's sometimes important to go and look back more than one scan. But the bottom line is, if there's significant progression on scans, and there's a reasonable treatment option, it's often a good idea to change treatments, even if you're feeling relatively well.
Okay. Dr. Haider, anything to add?
I agree. I mean, it's always our culture here is an open discussion and teamwork with our patients, but I think what I would highlight is we don't want to wait till a significant progression that then becomes debilitating or very symptomatic, and there's a rush to make a decision. And I absolutely want to re-highlight your comment, Dr. Strosberg, that we should not look at only one point, but if there's incremental progression that we have been monitoring or holding, then we should look at that timeline over time as well.
Okay. Is there any chance for surgery after I'm diagnosed with stage 4 disease?
Yes, and I think this, highlights my previous comments about tumor board, where this is very different from a stage 4 melanoma or stage 4 breast cancer, where surgery really does have a defined role in stage 4 disease, and we give that benefit of discussion for our patients within our tumor board or multidisciplinary team. That said, it really is suitable for lower grade tumors and does not quite have a role for high grade tumors or neuroendocrine carcinoma, wherein systemic treatment really is the lead.
All right. Is a gallium scan better than a copper, or is a copper better?
They're both about the same.
Okay. All right, this one has come up on a few of the past for various net meetings. Can you comment on histotrypsy in nets and when will it be available? So, yeah.
If I knew what it was, I could comment on it. Histotrypsy. Doesn't ring a bell. Mena, are you familiar with that?
No, I was waiting for for your response.
I think it's a type of ablation.
Oh, I know. I'm sorry. I
Yes,
believe this is ultrasound guided
yes.
ablation, and
Oh,
I'm
okay.
familiar with it because there was a clinical trial here in Tampa. To my knowledge, that is yet to be published. It is not standard of care, and if we were to look at it, we would have to design it within the clinical trial. I do believe that the one that was open would include neuroendocrine tumors, but I'm not sure. So the bottom line is that we are not currently using it. It is on trial and may have a role if proven to be helpful.
Were the trials neuroendocrine specific, or that was
No.
like a basket
It
trial?
was liver tumor, and I believe it would allow neuroendocrine, but you know, at that time when we were discussing, it was colorectal cancer.
Okay. All right. Are there any treatments available in Europe for neuroendocrine tumors that aren't yet available in the US? Let's say outside of Europe as well, anything?
I'm not aware of anything, no.
All right. Can a tumor change grade over time, and does that change the type of treatment available to me?
Yes, tumors can change grade. It's not that uncommon for tumors to become more aggressive over time. And in some cases, we think they can transform all the way from a low-grade tumor or an intermediate-grade tumor all the way to a poorly differentiated neuroendocrine carcinoma. It's not that common. We see it more with pancreatic nets than with small bowel neuroendocrine tumors. But yes, it can happen. And generally, it's associated with very rapid disease progression.
And that would then, you know, open up a discussion about different treatments that perhaps we would not have considered at a more indolent biology.
Right.
Okay. When do you recommend a clinical trial for your patients? It's a pretty general one, but I'll let you both kind of take that.
I'm sorry, can you please repeat? What
Yeah,
would I recommend?
When would you recommend a clinical trial for your patient? It's a very broad question, but.
Well, I think we will both answer it, but for me, it's at every meeting, I'm looking to see if there's a clinical trial that they should learn about. So for example, if I'm meeting a patient in consultation and they have not started treatment and I have a clinical trial that's a first-line treatment, like for example, for neuroendocrine carcinoma that I mentioned, I will make sure that my patient knows about the clinical trial, and then a decision-making point. So if we have progression and I'm able to offer a clinical trial at that time, we will make every effort to make that an option.
Right, I agree. I mean, some of our clinical trials are for patients who have sort of exhausted standard of care, and some are for patients who may not have exhausted standard of care, but it's felt that a experimental drug might potentially be better than what the standard of care is.
Okay. And I would highlight also in our section that not all our trials are treatment specific. So we are looking at multiple questions to better serve. And one of them is, for example, understanding what type of PET scan is most suitable for neuroendocrine carcinoma. That's not going to change our treatment pathway or timeline, but it is a clinical trial that we would discuss.
Okay. Another question is alpha PRRT showing fewer side effects than Lutathera. There's only so much we can talk about.
Yeah, I don't know if I can talk so much about drugs that are just starting out clinical trials, but as a general point, I would say they show different side effects. For example, we see a lot more hair loss with alpha PRRT than Lutathera. There are some other side effects that may be emerging. But and if someone is interested in a trial, we can go into that in more detail. There may be fewer hematologic side effects, in other words, side effects on the bone marrow, although I can't say that for sure yet. And I'm not aware that leukemia or myelodysplastic syndrome has yet been described with alpha therapy, as opposed to Lutathera, where we know it happens in about 2 to 3% of patients. But it's still early, and we really need a lot more information on both what the efficacy and the toxicity of alpha therapies are.
Is PRRT delivered straight to the liver better than PRRT through the IV?
So there have been some studies of delivering PRRT into the hepatic artery, in other words, straight to the liver in patients whose disease is primarily or exclusively in the liver. So far, I'm not aware that it's shown any great advantage over intravenous administration. So I don't think that that's going to be something that will become a standard in the future.
Okay. Dr. Haider, maybe you can talk a little bit about embolization. So there's a question on, can you describe the different types of embolizations and why one might be recommended over another?
Well, embolization has proven to be an important treatment tool in neuroendocrine oncology. It's best suited for disease that is dominant in the liver. So if we have a scan and there's a lot of activity outside of the liver as well, then focusing on the liver is not well suited. But if we have liver masses that are progressing and we are not able to offer surgery and no other area has progressed, looking at an embolization is a very good resource. We often use bland embolization here, which means we're not using chemotherapy beads or radiation, but it does come in those two forms as well. It's provided after a meeting with our interventional radiology team who administers the treatment. In many cases, we request our patients to stay overnight to control pain and then recover at home with some flu-like symptoms for the upcoming week or so. And then we obtain our next set of scans to see what we have achieved. Embolization is not limited to once in a lifetime, so embolization can be reused in the future, but ideally what we want to see is a good response for, in my opinion, Dr. Strosberg, at least 6 months or more to reuse it in the future. Otherwise, I would look at other treatments if we're having progression. At present, there was a clinical trial looking to see is one modality superior to the other. That hasn't been quite yet established. So the decision is patient specific upon discussion and what suits best.
Okay. Anything to add, John?
No, that was nice.
All right. The last question that I have that was sent in advance is for each of you to answer, but what's one development that you're most excited about and why?
Sure, I can take that first. I think but let me first mention, by the way, there's a new drug, cabozantinib, that we just heard an announcement last week that the trial was positive. So that's a new drug that will likely be approved for neuroendocrine tumors next year, it targets certain receptors on the cell surface, including the vascular endothelial growth factor receptor. So among other things, it reduces blood vessel creation in tumors, and it's used for other cancers. But we just completed a large trial, and I'm happy that we participated in it. And it's going to offer a new option for patients with neuroendocrine tumors. But as far as things that I'm most excited about, I do think alpha emitters are quite exciting. It's a completely novel type of radiopharmaceutical, and I'm hoping it offers even more benefit than lutetium. But again, we need to wait for the data to come back. At Moffitt, we're also working on cell therapies, things like CAR T cells that target the somatostatin receptor, as well as bispecific antibodies. So these are really cutting edge technologies that have been used in other cancers. We're hoping that we can get them to clinical trials. But that, if those turn out to be successful, that could be a completely new way of treating neuroendocrine tumors.
All right.
In addition, I have a large volume of neuroendocrine carcinoma patients that I see, and I'm very excited about our clinical trial to hopefully update how we initially treat, and perhaps see if immune therapy has a role, perhaps even with a maintenance phase that offers a continued treatment for our patients.
Okay. Anything that either of you would like to add to the discussion so far? And everybody on the call, feel free to add any questions that you have that we didn't already touch on.
Well, I will add that our Neuroendocrine Awareness Month is coming up. And so I look forward to increasing education and collaboration in our network.
Yeah, this support group that we're starting is new, and I hope through social media or other means we find a way of reaching more patients. Those of you who are in the audience who belong to other neuroendocrine groups, please spread the word that this support group, specifically in Florida, exists, and hopefully will be helpful to patients who live here.
And all these videos, these webinars are posted on the website and on YouTube after the fact. So they remain an ongoing resource for patients and caregivers and anybody else that you'd like to share these with. If there are no other questions, we can wrap up a little early, but if anybody does want to chime in, you're welcome to unmute or send a message. Not seeing anything come through, but some thank yous.
Thanks.
Well, thank you both for your time today and for all this information that I'm sure will be helpful. And like I said, live on for patients to come. And if there's any other topics that you want to see at any of these webinars, feel free to send them in. We do have a contact on our website that you can send in any emails or any requests there. Feel free to comment on any of the videos as well. That will help us to make sure that we're targeting the information that you do want to see.
Great. Thanks.
Thank you so
Well,
much for your
thank you
time.
guys.
Bye-bye.
Bye guys.